In episode 21, we're going to finish off with BBD and look at the evidence, which is pretty sparse, except for Dr. Bowen, given by the expert witnesses. First of all, we need to recap. The pathology report on the death of BBD stated that death was caused by pneumonia and acute lung injury. So, first of all, let's talk about what both of those are. So the pathophysiology are the mechanisms by which acute lung injury happens. There's a disruption of the normal barrier functions of the pulmonary endothelium and epithelium. So that's the inside and outside of the cell that are there to prevent noxious substances entering the alveoli. And the development of protein-rich interstitial and alveolar edema. So what that means is a swelling of these little airways plus the connective tissue in between them. And that swelling is going to have a very detrimental effect on the ability of these small airways to exchange gas, which is their only function. This leads to inflammation and potential progression to fibrosis. Now, fibrosis would be a longer-term effect. Fibrosis is another word for scarring. And for pneumonia specifically, the organisms are typically acquired from the mother or the hospital environment. And the pneumonia is early onset, so it begins at or within hours of birth, often as part of a generalised sepsis. So the lungs and the air sacs, that's the little alveoli, become infected. That results in inflammation, which is a damaging process if it's not properly controlled. And it is the inflammation that causes the lung injury. This usually results in respiratory distress and systemic illness like temperatures going up and down, acidosis, the failure to be able to control energy production. The immune lung defences are the biggest reason for this in babies, and compromised mucociliary clearance. So this is what we would normally do when we cough up stuff. If we have a cold, that's mucociliary clearance. And that mucus contains pathogens and we're clearing them out of our airways. But babies can't really do that. And the consequences of all this is ventilation, perfusion mismatch, increased work of breathing, hypoxia, respiratory failure, acidosis, and all the things that we talked about in episode 20, cytokine storms, massive lung damage and damage to tissues outside of the lung as a part of a systemic process. Now, all of this can be seen on histopathological samples. So when the pathologist looks through the microscope at the tissues under examination, they can see all of this, and they will particularly see what's called neutrophil infiltration. So that's the little white cells, the numerous white cells that will infiltrate the area to try and fight this thing off. But unfortunately, neutrophils are also the source of the inflammation. So even though the inflammation is necessary to fight the infection, the inflammation is in itself damaging if it's not controlled, and these poor neonates simply don't have the physiology to control it as well as an adult would. So the duration of this process, particularly when BBD was born and collapsed very, very quickly, so that's within hours, was on a ventilator within hours. That indicates that the infection and the inflammatory response was very rapid, and that can only be because the baby was infected in utero before she was born, or whatever the pathogen was that caused the pneumonia was extremely virulent. So it resulted in a very rapid cascade of inflammation. Because remember, poor BBD only lived for 2 days. So in order for you to develop all of that inflammation, pneumonia, all of the things identified, the inflammation and pneumonia identified, classified at the postmortem, It only had 2 days to do that. So that means that the process was extremely violent and extremely dangerous. So if we're comparing this to adults, like term babies and adults, we have to take into account the extreme immaturity of the immune system in the baby. So they have lower levels of what's called complement proteins, and complements are just proteins that are synthesized mainly in the liver and circulate in an inactive form until they're triggered, and they complement the adaptive and innate immune system. So they are very important, but babies don't have as much of them. And immunoglobulins are just a fancy word for antibodies. And there's different classes of them. And again, in pathology, the prevalence of the class that's found in the blood can give a fairly good indication of when the infection started. So the presence of an antibody called IgM would be the first one you would see. And that would persist for a few days and then give way over time to the IgG antibodies. So these are the scientific methods by which a competent pathologist can put a reasonable estimate on the sequence of events. But acute lung injury and pneumonia are not caused in any way or related in any way to pulmonary air embolism. They have completely different pathophysiology. They are not remotely related. And the failure to get the pathologist into the court to explain his or her findings was a major, major disadvantage to the Lucy Letby trial, and indicates that the trial is not fair. So Dowie Evans, the chief witness, gets to speculate and invent causes of death that are not subject to the same type of forensic analysis as the actual postmortem. And if I can impress anything on people, I wish I could impress that. Doctors rely very, very heavily on the information we get from pathologists. And there is no better way to find out how death occurred than through a competent autopsy, none of which were discussed in any detail in this trial. So what I'm trying to say is we have to bear all this in mind, that even on day one of this baby's life, a lot of very complicated, dangerous and destructive processes were underway, and those processes would not turn off for even weeks. It might take weeks before they would turn off. So we'll move on to Dr. Ryland's cross-examination, because the examinations from the prosecutors are a waste of time because they just stay away from the stuff that really matters. So we'll look at Ben Meyer's attempt to drag some of this stuff into the open. So, for example, in the prosecution cross-examination of a junior doctor, Dr. Rylance, again, none of this is the fault at all of a junior doctor under training. The doctor tells the court that Child D's condition was, at this point, responding well to interventions and appearing to be stabilised on CPAP and making respiratory efforts. Overall, I was happy with the progress she had made, but she needed to be closely monitored and assessed. Now again, we go back to the question, why on earth does a term baby and a healthy mother with good antenatal care need all of this? What caused her to need all of this? What caused the pneumonia? I suspect that what caused the pneumonia was the fact that the membranes ruptured and the mother was kept in the ward and exposed. And over the short period of time even that she was in that ward, she started to develop signs of being ill herself and also signs of fetal distress that she did not have at all. So that gives you the kind of idea Dr. Rylance goes on to say that there was an insertion of an umbilical arterial line and an umbilical venous line into child D, but they couldn't actually do it. The umbilical arterial catheter was inserted to 20.5 centimetres, so that's a long way, but did not get a blood sample back. An X-ray review found it was advanced way too far, and the route was not typical of a USC. And the blood gas readings were taken at that time and were much improved, but we don't get what the blood gas readings were. Then a second X-ray showed the USC was in a better position, but the route was still not typical. The much improved blood gas reading was, Dr. Rylance believes, a comparison with the previous blood gas reading. And then we find out that the umbilical venous catheter was actually an umbilical arterial catheter that was adjusted to be used as an umbilical venous catheter. And these are not the same things. The angles, the shape, etc. of these two types of catheters are different, and it is not advisable to use one as the other. And of course the plan was to continue CPAP for child D and repeat the blood gases and try to sample the UVC for various readings. And we go on. Child D had been on CPAP all day, but in air and saturating well with no desaturations. The initial blood gases post-extubation at 9 a.m. were not good, so child D was put back onto CPAP. The doctor also adds the diagnosis of sepsis to her notes, and overall my observations were that she was stable and handling well and responding well to treatment she had received throughout the course of the day. But then she makes, under impressions, stable on CPAP, tried taking her off, but respiratory efforts became irregular and desaturated a few times, so put back on. So again, this is this desaturation, or as I like to say, failure to resaturate. She needed a bit more time on the CPAP, allowing us to transition, having been ventilated, and moving to breathing. And if they don't seem to tolerate it well, you can just put them back on CPAP. We could go into a long discussion about weaning, but it certainly does not seem appropriate to me to be weaning a baby on day 2 when it needed ventilation, invasive ventilation, to stabilise blood gases. It's been diagnosed with pneumonia and it will end up with acute lung injury. So we'll just move on then to the cross-examination. We see just slightly how different this is. So Ben Myers for Letby's defence is now asking Dr. Rylance questions. And he says there were 2 instances of her examining baby D. He said that at the end of June 20 examination, she was happy with the child's progress. Would you agree she was at risk of complications? Dr. Rylance says she had responded well to treatment, but the blood gases were not in the normal range, and that would require close observation. But the problem is that observing the blood gases is not going to put them back into the proper range. Mr. Myers points out to baby D having lost colour and floppy when in her father's arms moments after the birth, which had bugger all to do with the father. Do you agree that is a worry at that stage? Dr. Rylance agrees that the APGAR scores of 8 and 10 and 9 and 10 aren't relevant for 12 minutes later. So we get the number there, 12 minutes after birth, the baby collapsed. And it's hard for me to imagine how APGAR scores of 8 and 9 were actually applied to the baby. If that's true, something catastrophic happened at 12 minutes to change that. But what catastrophically happened? The father picking the baby up? Absolutely no way. Because why would that then go on to need ventilation, diagnosis of sepsis, antibiotics, all of those other things? It's just ridiculous. And So she goes on to say that, in my opinion, at the end of the shift, my reference point is from when I first had contact with her at BBD on the neonatal unit, from when she required ventilation support. I wasn't involved at her birth. I can't comment on her condition at the time, so we know that there was no doctor present at the birth then. And Mr. Myers goes on, you will have known she started grunting in theatre, reviewed after 1.5 hours, grunting, but otherwise observations okay. So Ben Myers asked if grunting can refer to respiratory effort difficulties. Dr. Ryland said, yes, it can. And, you know, each of these little things, the grunting, which is also known as pharyngeal breathing, so the baby's trying to keep its lungs pressurized. Each of those little things can indicate severe problems. It's the subtlety of all of these things that will catch people out. And when you work with these little babies for any length of time, you learn that you get caught out very easily if you just say, oh, it's only grunting. Dr. Ryland says she is unable to recollect whether she saw baby D prior to her neonatal unit admission, but does not believe she was involved in the review to bring her to the unit. Again, I don't know what that means and why is it not noted. From the point she came into the unit, these were my direct observations. So Myers goes on and he says, he asks Dr. Rylands about the 7:30 p.m. review. Myers says she presents as a baby who is seriously ill. Dr. Ryland says, yes, at that point she was an unwell baby. So again we have this minimising language, an unwell baby. No, she was seriously ill. It could be argued she was critically ill. Dr. Ryland says she believes the first time she reviewed BBD was in the neonatal unit. Had she done so before, she would have noted that from a ward observation. The venous gases taken at the time showed marked acidosis, and Dr. Rylands agrees. And we notice that the prosecution doesn't bother going near such things as marked acidosis. Not just acidosis, marked acidosis. And we all know what that does. It'll shut down everything. Mr. Myers, you explained to us these are abnormal and indicate difficulty with the respiratory system and the metabolic components. And Dr. Ryland says that's correct. And the metabolic components are everything that needs energy. Myers says that those reasons are taken into account the clinical condition for BBD. And Dr. Ryland says yes. Mr. Myers says, but at this stage, weighing up the clinical picture, it's not a good picture, was it? Dr. Rylands, no. So Dr. Rylands is now admitting that this was not a good picture. But if you read the prosecution cross-examination, that's not the impression you would get. Mr. Myers said at one point Dr. Rylands had referred to the examination as being normal, but there were quite a lot of child D being abnormal. Dr. Rylands says child D was not a healthy baby at this point in time. She said she is aware baby D was later put onto a ventilator. Mr. Myers says infection is a leading cause in neonatal deaths and can develop very quickly. And Dr. Rylands says it can. As a rule, antibiotics should be given to a neonatal baby, and there are different guidelines of whether babies should receive antibiotics with clinical risk factors. When you have concern, then you want the antibiotics as soon as possible. Mr. Myers said baby D's mother had her waters broken many hours before giving birth, and the baby D was at birth floppy and risk of collapse. So why did Mr. Myers not have an expert witness to explain what that actually meant? Dr. Rylands agrees baby D should have received antibiotics at this stage. She adds this is reliant on someone else's documentation, and it's difficult to say precisely how child D was responding at that time. So we now move from child D was a stable baby to its difficult to say precisely how she was responding. She says it would have been a good idea to start antibiotics as quickly as possible, and that was done upon her arrival at the neonatal unit. Mr. Myers, the reality is, from the point of collapse at 12 minutes, given everything we know, the plan would have been give antibiotics rapidly. And the response from Dr. Rylands, yes, I think so. Again, minimising. Mr. Myers said baby D was not given antibiotics until nearly 4 hours after birth at the neonatal unit. But we know that baby D was essentially ignored for 4 hours after the birth, even though it was apparent to the mother that this baby was not well. And now we have an admission that she is not a well baby. She's seriously unwell. There was a 4-hour delay in the delivery of antibiotics after birth. Yes, she says, you may not be responsible, but that falls below the standard of care for a newborn baby, doesn't it? Yes, she says. The purpose of the antibiotics is to treat and reduce the risk of infection. Yes, she says, and I have tried to explain that it's to reduce the inoculum, the amount of pathogen present, so that the inflammatory response does not have to be as destructive as it will end up being. Mr. Myers refers to the blood gas readings on the afternoon of June the 21st. So we're talking about hours before the first collapse of this baby. Dr. Ryan says there would have been blood gas chart, and the readings were presumably an improvement on what was previously taken. But we don't have any blood gases here we have to presume that they're better. And then she was on to tell the court of the intention to insert a UVC and a USC if it's possible to do so. And Mr. Myers then refers to the presumed sepsis comment in the notes. So the doctors are presuming the baby has sepsis, so pneumonia and sepsis and bad blood gases. So Mr. Myers refers to an attempt to take baby D off CPAP by Dr. Rylands, as noted, and an accompanying nursing note referring to oxygen levels desaturating to the 80s. He says, that is not a healthy state to be in, is it? And her response is, it reflects she needed more respiratory support. But in fact, she had moved on from ventilator support and needed no oxygen support, suggesting it was improving. By trying to take her off CPAP, we wouldn't have done that if she wasn't stable. But we know that the baby is not stable because she's admitted this is not a healthy baby. So let's just trial her off CPAP within 24 hours, 48 hours with the diagnosis of pneumonia, respiratory distress, and we've already got readings of metabolic and respiratory acidosis when she came off the primary support, which was the invasive ventilation. And then it's just casual if she didn't tolerate it, so we can put her back on. The improving clinical condition, Dr. Ryan says, was from baby D arriving at the neonatal unit to her observations the following day. Mr. Myers says the satisfactory examination of baby D was carried out while she was on CPAP. So they start talking about lumbar punctures then, but no baby ever had a lumbar puncture in this unit. Mr. Myers said Dr. Rowlands had identified sepsis and acidosis at various points, and during the time she was caring for baby D, she required breathing support. He says that when baby D was taken off CPAP, she began deteriorating, and Dr. Rowlands agrees. So we get pop-up prosecutor again. He gets another bite at the cherry to undo the work that Mr. Myers has done. And because Mr. Myers has no other witness to call, he doesn't get a second bite at the cherry. The prosecution, led by Simon Driver, rises to clarify about the notes made for child D following birth. At your last review on 7 p.m. on June 21st, What was your assessment of her at that stage? From what I documented, baby D was stable with minimal respiratory support and no additional oxygen support. So you can never say, I'm sorry, you cannot say a baby who is 1 day old, a term baby with pneumonia, that should never have had pneumonia, is stable when they're on positive pressure airway. People can disagree with me or not, but to me that just seems absolutely ridiculous. A healthy, normal baby that everyone would be celebrating with flowers and chocolates would be feeding on his mother's breast at that stage. It wouldn't be feeding off positive pressure ventilation. So we go through all the stuff. You can read it all yourself. Interesting bit from one of the nurses who gave evidence from behind the curtain. We get on to the rash again. It's just so nauseatingly stupid. This seemed to be a largely mosaic type rash. So now we have another description, and was a reddy brown colouring. So we're so far removed now from the cutaneous blue and pink flitting rashes that they were talking about in baby A. When I have mosaic type rashes, it was not like a spotty rash, it was an oval type marking on the skin. So we have an oval type marking that's mosaic. The vessels of the blood seem to be meeting up with each other. That's not a mosaic type rash. That's a reticular type rash. Sorry. So mosaic type rashes are usually genetic. They're very, very uncommon. But the reticular rash, which is the joining up of the blood vessels in libido, otherwise known as mottling, that is the vascular pattern. That's not the mosaic pattern, and reflects blood flow changes and vascular anatomy and that kind of stuff. And the pattern becomes more apparent when deoxygenated blood accumulates in the venous plexus near the skin surface. So the venous plexus is just the network of veins that serve the surface, and it makes the net-like appearance of the blood vessels more visible. So that's not a mosaic rash. And of course the witness says that the discolouring seemed to disappear and dissipate after a while, and that baby D settled back into a normal pattern of breathing after doctors assisted with the intervention, which of course it did because it was mottling. And then Ben Myers comes in and he says, asking if the extra detail she had provided about the rash compared to her police statement was something she may have picked up in conversation at work. And the nurse replied, I might have done, but it's also my recollection which have come back. It was an odd rash. It wasn't like a normal septic rash. Well, I don't know what a normal septic rash looks like. There's so many different types, but it was a different type of rash. Yes, of course it was. It was the Letby rash. Mr. Myers said, can you help us with how you got the extra details? And the witness said, because I started thinking about the events as I was getting sleepless nights. I was thinking about the events that happened. So make of that whatever you will. Then we get on to more discoloration, stuff like that, you know. So then we reach the genius that is Derry Evans. So remember everything we've said about how the pathologist would be able to reconstruct events very accurately and assign classifications to them, such as pneumonia and acute lung injury. Whereas we now have paediatric expert Derry Evans getting cross-examined, and he's asked about mottling seen on baby D's body the first time she collapsed. Dr. Evans says it's very significant and extraordinarily unusual. This is not something that happens out of the blue. He's obsessed by blue, this man. Asked about baby D's condition immediately before her collapse, Dr. Evans says her condition could not have been better. Her condition was entirely consistent with a baby recovering from early onset pneumonia. She was doing exceptionally well and was clinically very satisfactory. The baby's hardly 2 days old. There is no way on earth that she's recovering from early onset pneumonia with sepsis after 2 days. And the inflammation, which he doesn't seem to know about, won't switch off for a couple of weeks. She was doing exceptionally well. Dr. Evans says baby D was recovering from early onset pneumonia, not that she had recovered from it. So what degree of recovered? What evidence does he have that that is the case? What evidence does he ask for? What evidence does he present that he can distinguish from what, looking at notes, whether an early onset pneumonia that's less than 48 hours old is recovering? Not recovered, but recovering. And that the inflammation is not of any significance. There's no way he can. And Dr. Evans says his conclusion in baby D's case is that death was caused by an injection of air into her bloodstream, and not asked why or how an injection of air into her bloodstream caused acute lung injury and pneumonia. No. To me, this is just so utterly absurd. And again, if we put it to the test, what would happen to you in a professional exam if that is the answer you gave to why this baby died? They would show you the door. So Ben Myers goes on, has a whack at Evans. He says, Dr. Evans gives 5 reasons. Baby D's collapse was rapid and very striking. Well, all collapses are rapid and very striking. That's why they're called collapses. That's why they're called crashing neonates. The presence of discoloration on baby D's body, a pattern experienced nurses and doctors had never seen before and never seen since, and it came and went. So these are Evans's reasons for his diagnosis. So we're ignoring all the acidosis and inflammation and complements and cytokines and all that. We're ignoring all that. And we have to remember that we have about 15 or 16 different descriptions of the rash by this stage, and a lot of which were not noted at the time, and most of which were added to after the police statement. So it's not really what a doctor would regard as reliable evidence. Attempts to resuscitate baby D were unsuccessful, but we had 2 attempts to resuscitate baby D, which were very successful. And they were successful because they provided baby D with the oxygen it wasn't already getting. And number 4, the presence at post-mortem of air in baby D's blood vessels. I've said it before and I'll say it again. Unless you do gas chromatography on that gas, you cannot say what the gas is. So the presence of post-mortem air is an assumption without any evidence whatsoever. And then finally he says, none of the other issues, example pneumonia, were relevant. So the cascade of hyperinflammatory destruction of the lung caused by the pneumonia was not relevant. What we have in baby D's case is a full house of clinical characteristics consistent with her having suffered an air embolism, i.e. air having been injected into her, said Dr. Evans. Dr. Evans agrees with the defence that baby D was in a state of very poor health when she went to the neonatal unit. Mr. Myers refers to Dr. Evans saying baby D was recovering from pneumonia and suggests that she still had the potential to become quite unwell. Dr. Evans says she was in a neonatal unit, the best place on the planet for her. And that's the biggest joke of the whole lot. The shitty neonatal unit, literally, that this baby was on was certainly not the best place on the planet for her. When asked by Mr. Myers again about her potential to become unwell, Dr. Evans says, the potential is there, which is why she was on a neonatal unit. So no attempt here to be honest about the dangers that these babies are in. And that everyone knows the dangers that these babies are subject to. Mr. Myers suggests Dr. Evans doesn't want to accept problems with baby D's respiration because that would undermine his conclusion that baby D died from air embolism. And Dr. Evans says no. So there again, there's nothing medical in that I would consider medical. As one doctor to another, I don't understand the blathering that's going on here, given that we have so much detail from the postmortem. And then we move on to Professor Owen Arthurs. Maybe I'll get his name right this time. And he's recalled to give evidence in respect of baby C and baby D. Professor Arthurs is now giving evidence for baby D. He has examined radiograph images as part of his report. Now, it's very interesting that Professor Arthurs is a very learned man, a man with a very good reputation, who writes enormous amounts of papers on the use of CT scanners, micro CT scanners, MRIs, whole body imaging, babygrams, and all that kind of stuff. But he never mentions X-rays because he doesn't use them. And if we read his papers, which I have done, he says that X-rays are pretty useless except for less than 5% of post-mortem evaluations, and mostly then they're related to dysplasia or poor formation of bone or bony injuries, gunshot wounds, trauma, etc. And he is introduced here all the time as an expert in all of these different modalities of imaging, but none of these modalities of imaging were used in any of these babies. So the entirety of Professor Owen's sterling work on what he calls non-invasive autopsies isn't really relevant to any of the stuff he's written. So he talks about the first one. This was the radiograph image on June 20th, is presented to the court, in which there are no abnormalities seen. The second image is effectively of the whole body, is shown to the court on June 21st at 1:30 p.m. Professor Arthur notes two features, the obvious one being the UVC going up towards the heart, which had been pushed in too far. The subtle observation was a sign of infection in the child's right lung, but the magnitude was nothing like that seen in baby C's case. But Professor Arthur should know, I'm sure he does know, that chest X-rays have limitations in diagnosing and assessing the severity of neonatal pneumonia, and their findings don't always correlate with the clinical severity. There can be similarities between pneumonia and other conditions, like respiratory distress syndrome on X-rays, and he has already referred to these as subtle. Making definitive diagnosis pretty challenging. Clinical symptoms and laboratory findings are more important than X-rays alone for assessing this stuff. And to be honest, I don't think the X-ray findings here are that important, really. So in one study, which I'll quote, 34% of neonates with respiratory disorders had normal chest X-rays. So without signs of infection, a consolidation on an X-ray is unlikely to indicate pneumonia. A lot of people think that ultrasound, which would, I hope, be available on level 3 units, is just a much better way and safer way to get this information. But he carried on. The third X-ray image was taken on June 22nd, 1:15 a.m. after the child's first collapse. The UVC line has been withdrawn slightly, so we have a UVC line in, so we have a source of our embolism. He explains the UVC is in a loop and is almost certain to be outside the body. But we know that the previous X-ray reports on this UVC, UVC, was that it was in an atypical position and it was pushed in too long. And then he goes on to say, there is nothing unusual in the appearance of the diaphragm it looks pretty clear, indicating a potential infection. Looks like it has improved. And there's absolutely no way a chest x-ray can tell you that. And I'm sure Professor Arthurs would agree. Professor Arthurs says it's difficult to gauge between one x-ray and the other, but it would be consistent with an improving picture for a baby in error throughout that time. So again, consistent with is no level of proof in medicine at all. A further x-ray image taken at Alder Hay Hospital after baby D had died, so another post-mortem x-ray, is shown to the court. The UVC is still in, and a black line just in front of the spine is a striking feature. Professor Arthurs says error is present, and what the court hears is the main highway of the circulation. Again, Professor Arthurs cannot know that a black line on an x-ray is error. It could be another type of gas, a decomposition gas. He cannot know that it is error. Professor Arthurs says the significance of that is that it is an unusual feature in babies who have died without an explanation. Well, we have an explanation for why this baby died. It died of sepsis, which we know Professor Owens already said was a cause of this gas in the main highway of the circulation. He said that in the case of baby A. The baby had sepsis, so it shouldn't be a particularly unusual feature because we have an explanation. He adds that the amount of gas is consistent in babies who have died of sepsis. There we go. Sudden unexpected death in infants with road traffic collisions, and 2 other babies in a trial. Another was baby A. But unfortunately, a 2D image cannot quantify the amount of gas. A 3D image perhaps that Professor Arthurs used to using, but again, you can't quantify the amount of gas from a 2-dimensional image. It's simply not possible. He says one of the other explanations what needs to be considered is deliberate error injection. He says the most plausible conclusion was in the absence of any other explanations, and we have other explanations. We have CPR, we have ventilation, and we have an umbilical venous catheter. Those are 3 perfectly acceptable explanations, plausible explanations. So they're not absent from any consideration of an error embolism, but the most plausible conclusion was they were consistent with, but not diagnostic of, deliberate error administrations. He confirms he has never seen this before in his experience. So again, we have ignorance of something being proof of something. So Myers has a go at him. He asked if it was correct that at post-mortem stage there were normal amounts of gas found in the normal areas, including the bowel. Professor Arthurs agrees. Mr. Myers asks about how often gases are found post-mortem. Professor Arthurs says for a quarter of those cases of which he found in examinations in Great Ormond Street Hospital, there were gases found in the bladder vessels for which there were explanations of post-mortem gases. He adds, if there is an overwhelming evidence of infection, which we have here, it can lead to gases appearing there, or potentially gases being redistributed in the body during prolonged resuscitation efforts, which we also have here. He says administration of air is one of the explanations. It is the single least likely explanation, in my humble opinion. And I will leave a whole list of Professor Arthur's laudable papers on non-invasive autopsy, and I challenge anyone to find anything that makes any reference to the use of radiographs or x-rays to diagnose our emboli. And then we get on to Dr. Sandy Bowen, medical expert witness. Dr. Sandy Bowen is giving evidence on BBD and confirmed she's made a report on her having had access to relevant medical reports and images from the Countess of Chester Hospital and other plus other medical experts. She confirms her role to peer-reviewed diary evidence. Dr. Bowen says there is now an advantage in delaying the cutting of the umbilical cord by 2 minutes if the baby's in good condition, which is true in premature babies. However, if the baby is in extremis, the priority is on saving the life, and cutting the umbilical cord immediately is the priority. Dr. Bowen said the cord was cut for baby D after 2 minutes. So, what does that mean? It doesn't mean anything, because 15 minutes later, the baby collapsed. She said baby D was in some respiratory distress due to grunting. And again, I told you that grunting, like the x-rays, cannot in themselves tell you how severe the respiratory distress is, which started when she was taken into the postnatal ward. No, it started before that. It had been noted by the parents baby D was floppy and dusky in colour. Upon similar observations by medical staff, child D was taken to the neonatal unit. Dr. Bowen noted baby D was put on CPAP with 40% oxygen, and during the night she had improved but was still not normal. So much for delayed cord clamping then. She tells the court there were still signs of respiratory distress for baby D. Dr. Bowen confirms she has noted that medical staff noted during their observations and records. She noted the skin discoloration observations for baby D at the time of her first collapse at 1:30 a.m. on June the 22nd. So here we go again. The skin discoloration, and let's ignore all of the other fuckery that went on with the ventilation trials and CPAPs, oxygen, no oxygen. Just ignore all that. Dr. Bowen says she would not have been surprised if an infection was the sole cause behind baby D's catastrophic collapse. The original cause of death post-mortem was pneumonia with acute lung injury, Mr. Johnson tells the court. Dr. Bowen explains, in her opinion, baby D's condition at birth was good, with good ABGAR scores and delayed cord clamping, which would not have been done if baby D was not in good condition. So what the hell does that have to do with the findings of the post-mortem? It has nothing to do with it. She says, upon the observations of child D becoming floppy in her father's arms, she says, upon the observation of baby D becoming floppy in her father's arms, first-time parents are desperately keen to have their babies with them, with skin to skin, which has a number of benefits. Dr. Bowen says she means no disrespect to baby D's parents, who were first-time parents, that the father could have held baby D in such a way as the baby put their head on to the father's chest, and that can collapse slightly her windpipe. Now listen to this crap. The father has slightly collapsed the baby's windpipe. So this is a lusty baby, she's saying, you know, that 6-pound full-term baby. You try holding one of them in your arms and there's no way you're going to collapse its windpipe. It's just sucked in when the shoulders are pushed up. But even if it did collapse the windpipe, how does that explain the pneumonia, the respiratory acidosis, the metabolic acidosis, the sepsis? Did the father cause all that as well? And she means no disrespect to say that to a man who has lost his baby. I cannot tell whether this was a clinical collapse or simply an unusual position of the head. You may not be able to tell that, Dr. Bowen, but I can certainly tell it. Dr. Bowen noted the inconsistent temperature for baby D showed signs of infection, and baby D should have been screened at that point. Well, was that the father's fault too? With no disrespect to the father, was that his fault too? It was when baby D refused to feed that she was then later transferred to the neonatal unit. And she doesn't mention the fact that the mother had to cry for help more than once. So we just have refusing to feed now as the reason she was admitted to the neonatal unit. And that refusal to feed is going to result in her needing to be intubated. Dr. Bowen says newborn babies usually maintain their temperature quite well, but premature babies require more monitoring. But we're not talking about a premature baby here. We're talking about a term baby, so why you mention premature babies? Baby D's temperature was low on arrival to the neonatal unit. Why was that? She says the nursing staff probably overdid it in increasing the incubator temperature, as baby D's temperature and heart rate rose to levels outside normal readings. So we know that low temperatures, high temperatures, fluctuating heart rate, all of these are well-recognised symptoms of sepsis. But no, the nurses overdid the incubator when they moved her to the ward. Dr. Bowen says the breathing rate was high and she required oxygen support. Breathing at that rate is hard work for babies. Rather than wait for them to be tired, it's much safer to intervene rather than wait for them to collapse. So, the clinical picture of baby D was consistent with infection, Dr. Bowen says, even if the X-ray image did not show that. So we have a baby with sepsis that the father nearly choked to death, with no disrespect to him. The second X-ray image showed a small patch of infection in the lung. Again, the X-ray doesn't tell you what the severity of that was in any way. Dr. Bowen says baby D throughout June 21st was well and stable. That's the day she had the acidosis, respiratory acidosis and mixed metabolic acidosis. She required CPAP, but in her, and was improving despite having pneumonia as an infection, and was getting better with treatment. What evidence do we have that she was getting better with treatment? We don't have any. Dr. Bowen says regarding the decision to begin feeds on baby D indicates the baby girl was stable, as feeds would not be administered if the child was not stable. So there's this kind of circular logic. Because we made a decision based on a misconception, that means the decision was right and the misconception was wrong. They didn't have any clear cause. Oh no. Then she goes. She says all three collapses for baby D were sudden and unexpected. Well, they came out of the blue. She recovered very quickly in the first two, and two of the episodes were associated with an unusual mottling of the skin, which went away the minute they gave it oxygen. They didn't have clear causes. Well, we have one where the baby had saliva bubbling up its mouth. We had the other one that happened once the baby was taken off CPAP. So we did have clear causes. She seemed to recover very quickly after the medical team's interventions, and she was well again. So the medical team intervened, presumably to clear up a cause. Dr. Bowen notes, for babies on CPAP, they will often find it uncomfortable and they will try fighting it. A baby who is relatively well will fight it. However, Dr. Bowen said in relation to one of the nursing notes, the fact baby D became upset then was a concern for me, as she had tolerated it well up until then. You were just leaning and leaning and leaning towards, like, the complications of CPAP or legion. They fail all the time, but no mention of all that. But she's concerned that the baby's getting agitated on CPAP, that the baby's getting agitated, and she'd been tolerating it well, then suddenly started getting agitated. Dr. Bowen says she believes the infection was acquired prior to birth. Oh, she agrees with something I said anyway, adding that the initial administration of antibiotics was late. So the infection, the acute lung injury, the inflammation, all that other stuff, it all started before birth. Had a really good chance to get going. And that resulted in a baby coming out with ABCARs of 8 and 10? I don't think so. Dr. Bowen said the medical team knew BBD had an infection, but there was nothing to indicate she was at imminent risk of dying. So can and do babies die suddenly? Can and do babies collapse and die suddenly from pneumonia and acute lung injury? Yes, they do. Pneumonia can cause acute respiratory failure, and it's a relatively frequent cause of death in infants, including neonates. And some cases, in many cases, can be unexpected because the children don't appear to be severely ill before collapse and death. Reference in the show notes. Neonatal pneumonia can manifest as part of early onset sepsis. So it's not just a pneumonia, it's a sepsis. And the signs can be limited just to the chest, but it can progress rapidly to shock and death. So, references. Sudden, unexpected postnatal collapse is actually a classification of death, and it's much more common in respiratory diseases like pneumonia. So, pneumonia kills over 250,000 newborns annually. Chest x-rays can't diagnose it properly. Laboratory findings are not even that good at doing it. Only about 2 to 5% of sepsis cases have positive blood cultures. And I think your chance of having an intrautero infection with acute lung injury in the shit-strewn ward of the Countess of Chester Hospital is pretty high. And I think that's probably what happened in this case. Delay in antibiotics, switching from one modality of ventilation to another, watching blood gases deteriorate, all of it I find disturbing from one doctor to another. And then we go on, more skin discoloration. She concludes collapses were caused by intravenous air administration either through the UVC or the cannula, but doesn't say why or how the air gets through the UVC or the cannula, because we know it can get through the cannula by surgical dissection along the route of the cannula. Dr. Bowen says in air embolism, the speed and quantity of air administered depends on whether it is fatal. Well, that's kind of a wee bit different than Darry Evans, who 3 to 5 mils, 2 to 3 minutes before collapse. So even though the times keep varying, 2 to 3 minutes was his estimation. She says the first 2 administrations of air would have been small, but the third would have been larger to cause the circulation to stop. So this woman has absolutely zero proof that anything like that happened, because no one witnessed Letby do anything, and we have other sources of error that she can't account for. So Ben Myers goes in. He says that in the absence of infection, there had to be something unusual and odd found. Dr. Bowen said she had looked at the clinical picture and had concluded the explanation most commonly found, which left the only conclusion as something unusual and odd. Mr. Myers asked about the relevance of child B being in distress, and Bowen said it was a possible explanation for what's seen in adults. They can be in distress after an air embolus. They can also be in distress because of hyperinflammation, pneumonia, sepsis, hypoxia, acidosis. But we're just going to ignore all that stuff, and we didn't bother bringing along an expert to counter this fantastical evidence. Mr. Myers says Dr. Bowen cannot apply to neonatal medicine what she's seen in adults. Dr. Bowen says neonatal babies don't have different biological systems, and a lot of the medicine relates to what has previously been done in adults. I'm sorry, but neonates have completely different biological systems, particularly in the immune system, particularly in the heart, and particularly in the lungs. She adds, BBD had been content with CPAP before, and her being in distress was a sign of concern. So that's called CPAP failure. It happens all the time. Dr. Bowen said BBD was taken off CPAP following the second collapse. in case she was being distressed. So in case, not because we knew, but in case. Mr. Myers, are you trying to find any evidence to support your error embolism conclusion? No, absolutely not, says Dr. Bowen. You just take any bits that you can find to support your diagnosis. Dr. Bowen, no, absolutely not. Dr. Bowen adds, in relation to the skin discoloration, the rash observation noted by medical staff were like nothing else as observed for any neonate. So there we have ignorance as proof of something. She adds she was not there, but those observations by doctors and nurses were not ones she had found in neonates before. Well, we've got, as I say, I can't remember, 15 to 19 different descriptions. She said she is not using skin discoloration alone. Well, they may not be using skin discoloration alone, but they're certainly shoving it in at any opportunity. And maybe even pop-up the cure will come in to reinforce that again. She's not using the skin, but it fits as part of a constellation of features. No, it doesn't. She says such discoloration would be circular with reddy brown marks which came and went and not mottling. But they were pink flitting rashes in baby A, and now they're reddy brown marks, circular reddy brown marks which came and went, and that's a perfect description of libido reticularis. She said there is no single distinguishing feature of an error embolism. And then we get into the 1989 Medical Journal review into error embolism is presented to the court, mentioning in particular cases of blanching and migrating areas of cutaneous pallor were noted, so that's white moving about, not reddy brown. In several cases, in one of our own cases, we noted bright pink, not reddy brown, vessels against the generally cyanosed background. We have many particular descriptions, Myers says. They do not all conform to this, do they? And she says, I think they're pretty similar. Oh my God. Nowhere in the clinical notes for any of the children in this have we had this description. We have seen reddy brown patches on a background that is cyanosed, so yes, we have. Mr. Myers says there is no uniform presentation of this skin discoloration to mark it against. Dr. Bowen says it's rare, so there isn't, and agrees that the 1989 Medical Journal is a reference of such evidence. She repeats that the skin discoloration observations are remarkably similar. They're not remarkably similar. They were mosaic a minute ago. Reddy brown mosaic. Chin on the trunk, maybe not the trunk. We'll actually list them all at some stage. Mr. Myers says there is no discoloration or distress in the third collapse. Dr. Bowen, discoloration doesn't present itself, but there are other features which do. So what are the other features? Dr. Bowen says there was a catastrophic collapse and error present in the great vessels post-mortem. There was not error present in the great vessels post-mortem. No one identified error present in the great vessels post-mortem. Gas chromatography would be necessary to do that. She said it was not just the rapidity of the collapse, but the severity of it, and that she could not be resuscitated. Here we go back to the resuscitation again. The poor child was so ill. What was her blood acidity at the time of the collapse? They don't even know. Mr. Myers said BBD recovered twice, which in principle is inconsistent with her embolism. Dr. Bowen disagrees and goes back on this old speed and volume of her administration, which she cannot know or even have any clue about. She said there is a treatment for her embolism. Mr. Myers refers to her embolism experiments in animals testing and asks how that can compare between animals and neonates. Dr. Bowen said experiments are not done on monkeys anymore. I don't know what planet she's living on. They aren't done on rats, but they are done on piglets, as the biology is similar. So we have similar biology to piglets, adults and neonates. Or Mr. Myers says Dr. Bowen refers to a medical paper in which testing is done on dogs and rabbits, What basis do you have? I have the basis in the literature, which is based on dogs and rabbits. Yes, but Dr. Bowen has already mentioned pigs and monkeys as well. Mr. Myers, Dr. Bowen, it's not ethical to do such testing in humans. So, again, what's that got to do with anything? So what that means is that we don't know. We do not know. We have experiments that we don't even have reference in here. We don't know if they were proper experiments, how they were done, what was used to put the air in, all that stuff. We don't know any of that. There's just dogs, rabbits, a menagerie dragged into court without any reference to where it came from. And Myers resumes questioning Dr. Bowen. He suggests Dr. Bowen has disregarded or minimised certain facts that show how unwell Baby D was, and Dr. Bowen disagrees. Of course she does. A nursing chart from June 20th presented to the court at birth. Mr. Myers says Baby D was very unwell at birth, and Dr. Bowen says she disagrees, even though she has agreed previously that the baby had pneumonia in the womb. Mr. Myers refers to the note at 12 minutes. She was very unwell indeed. Dr. Bowen said had an event which required intervention, but was not clear what her overall condition was. What a load of crap. Mr. Myers said she had referred to the father's handling of the baby as the cause of the event. Bowen said that was one possibility, but not the only one. Just like the air embolism, the father would try to strangle his child with no disrespect, out of ignorance. That was another one of their crazy possibilities. She said she was very clear the father was not responsible for the collapse, as new fathers are nervous with holding babies and you cannot tell there was an obstruction or part of a clinical condition, so why mention it then? Well, why bring the father into it all? And then she goes on to insult the mother. Mr. Myers refers to the nursing notes made in the hours following Baby D's birth. Dr. Bowen said it was clear by the time of the neonatal unit admission, Baby D had signs of an infection and was unwell. Mr. Myers said the mother had referred to being really worried about Baby D being limp and without colour, a bit grey, purple, making grunting noises, not responsive. That's a really poorly baby, isn't it, Dr. Bowen? And Bowen says, that's the mother's interpretation, but I can't believe the midwifery team would have allowed the baby to be fed or stay on the postnatal ward in that condition. But they did, and she wasn't fed, and that's the fact. She was on that ward for 3.5 hours. She tried to feed the baby and couldn't feed the baby. Mr. Myers says the midwife team did not administer antibiotics to Baby D at that stage, and Dr. Bowen said that would have been a medical staff decision, not a midwifery decision, to administer antibiotics. She agrees antibiotics were not administered at this point. It's very hard to disagree with that, isn't it? Dr. Bowen says the low blood gas reading would be a concern, but would need to be put in a clinical context. Yeah. Intrauterine pneumonia developed in the womb. That's the clinical context. That's now going to lead on to hyperinflammation with acute lung injury and all that means. Mr. Myers refers to a table of blood gas readings, and Dr. Bowen says they have deteriorated as child D was being monitored off ventilatory support onto CPAP. Mr. Myers says Baby D had an infection on June 21st, and that was not a sign of a well baby. Dr. Bowen said she was very, very clear. Baby D had pneumonia, but was on antibiotics and improving and coping with CPAP without needing to go on a ventilator. But a minute ago, she said that the baby wasn't coping on CPAP, and that was one of the reasons that it took her off the CPAP. She agrees Baby D did not manage well with being taken off CPAP and was put back on, so she's coping with the CPAP. Mr. Myers says the fact that Baby D saturates like that is a sign of poor health, isn't it? Dr. Bowen said the clinical team made a good judgment call in attempting to take Baby D off CPAP, and they cannot stay on CPAP forever. Well, she's only been on CPAP a day, and babies can be on CPAP for weeks. We're not talking forever. But it was perfectly acceptable for her to be put on CPAP, and she was quickly put back on it. Mr. Myers refers to blood gas reading at 1:14 a.m. on June 22nd. So this is just before the collapse, which he says is not normal, and a deterioration on the one before. Dr. Bowen says it is not as good as the one before, but is marginal and needs to be taken in the overall clinical context. The overall clinical context is that the blood gases are deteriorating, and in 15 minutes they're going to deteriorate even more. Mr. Myers asked if Dr. Bowen is sure she isn't trying to minimise such evidence as this in her overall findings. Dr. Bowen, I'd like to make it clear my duty is to the court to present my findings in an impartial way. Yeah, and I will leave anyone listening to this to believe whether they think that's true or not. Dr. Bowen says the lack of antibiotics at one stage was a blip in the care baby D had received, but she presented as a well baby throughout June 21st. And I think, personally, one doctor to another, that 99.99% of doctors in the world would disagree with that. Mr. Myers says about the decision to take baby D off CPAP after the second collapse. There would be a low threshold to intervene if there were further desaturations. He said baby D's desaturated again and says that there should have been a moment to increase ventilation support. And I couldn't agree with him more, but he doesn't have anyone there to point that out to the jury. But Bowen says not necessarily. Why not necessarily? She said the doctor would have noted the overall clinical picture for baby D. So this overall clinical picture, it's like a painting with no colours. You can imagine any colour you want. You just look at a blank piece of paper and say, this is a Van Gogh, this is a Constable, because it's my overall impression of the painting. Mr. Myers said, Dr. Bowen says, given the clinical parameters, that's the deteriorating gases at 1:14 a.m., the decision to take baby D off CPAP was the right one to make. Mr. Myers asks if baby D had respiratory difficulties throughout her life. Dr. Bowen disagrees. Well, which part of her life did she not have respiratory difficulties? And Myers goes, but she was on CPAP. And Dr. Bowen said, baby D was stable on CPAP, and it was not possible to see how baby D was breathing unaided unless she was taken off CPAP, which could have waited a couple of days without any problem while the infection was cleared up. And if she was on CPAP, she did have respiratory difficulties throughout her life. But Dr. Bowen disagrees. Dr. Bowen adds she believed baby D had died with pneumonia, not because of pneumonia. Well, she did die with pneumonia, but she had acute lung injury. Mr. Myers concludes by asking if Dr. Bowen has been influenced in making her conclusions rather than looking at the facts. Dr. Bowen disagrees. And I will leave you, dear listener, to work all that out yourself. So we'll finish up here with Dr. Andres Margaritis. Thank God he doesn't have a lot to say. I like the explanation. Her embolism into her circulation, that's really all there is there. Mr. Myers has taken the medic back over his evidence for child C, D, and now I, the defence lawyer, is focusing on questioning on the fact that he had to rely on Dowie Evans and other medics for his review. Dr. Margaritis earlier said to discount the clinical evidence informing his reports was akin to asking someone to explain physics without using mathematics. Yeah, well, we've been over that. But read and weep is what I have to say. So we know the cause of death for baby D was pneumonia with acute lung injury. We have Dr. Bowen saying, agreeing with me that the baby likely acquired the infection in utero, and I will add that I think the baby likely acquired the infection from the filthy sewage conditions of that unit, and that this baby was failed miserably and would not have died had it been in a proper unit. That's my opinion as a doctor. Dr. Bowen can disagree with me, expert or not. So in the next episode, we're going to move on to the case of baby E, a twin. And again, we have a murder allegation of air embolism and bleeding from trauma. So I'll see you in the next episode. Bye.